Hi, I'm Dr. Gloria Richard-Davis. I'm a professor in the Department of OBGYN at University of Arkansas for Medical Sciences. I'm a reproductive endocrinologist, and I'm also the executive director for the Division for Diversity, Equity, and Inclusion. And it is my pleasure to join you and speak on uterine fibroids. That's a topic that I'm very passionate about and have worked in this area both clinically and in research to include some of the clinical trials. So I'm going to go ahead and share my screen so that we can start to talk in depth about fibroids. Okay, so the impact of uterine fibroids, symptomatic uterine fibroids in particular. One of the first things I want to say is July next month, 2021, is Fibroid Awareness Month. And I wanted to make you aware of some of our professional organizations, as well as our consumer advocacy groups that you may want to take a look at if you're not already aware of them. So the American Society of Reproductive Medicine is our national organization for fertility specialists, reproductive medicine specialists, a multidisciplinary group which includes clinicians, researchers, social scientists, etc. Within that organization, we have a fibroid special interest groups that really just focuses on fibroids, again, from clinical to research, and I am the past president of that group. The other professional society is of Women Health Research. And earlier this year, the Society of Women Health Research convened a group of experts, national experts, and also included some of our consumer advocacy group, bringing us together to talk really about the state of fibroid knowledge and our current options in terms of treatment. And then two of the consumer advocacy groups that are very active is the Fibroid Foundation and the White Dress Project. So let's talk just a minute about what fibroids are. So uterine fibroids really refers to the development of these white swirly non-cancerous tumors, generally starting in the wall of the uterus. So if we look at this diagram here, this is an intramural fibroid, right? And so from the intramural position, it may start to grow outward towards the surface of the uterus, which is subserosal, or inward towards the endometrial cavity, which is then becomes submucosal. The fibroids that are clinically relevant in terms of future fertility is the submucosal fibroids, or anything that distorts the endometrial cavity. Those really need to be addressed because they interfere with implantation and they can cause early miscarriages. They typically tend to be, more symptomatic as well. So who develops fibroids? Well, we know that women of color, Black women, are more likely to develop fibroids, but there are some other conditions. If we have vitamin D deficiency or insufficiency, that increases the risk. There are certain markers or genetic markers like the COMT upregulation or estrogen receptor upregulation that tends to increase probability of fibroids being developed. And then there are other parameters like increase in weight or higher BMI, because there is the increase in estrogen production from the peripheral adipose or fat cells, as well as a chronic inflammatory process. Age at menarche. So anything that really increases the length of time that women are exposed to estrogen increases the likelihood of development of fibroids. So as we age, because we start menarche in our teens, the longer we are exposed to estrogen, the greater the probability that we will develop fibroids. And then, of course, there are women who have very strong family history of fibroids, or adolescents who have persistent heavy bleeding, menorrhagia, that again may be sort of a hallmark of fibroids developing. So I mentioned the chronic inflammation, and these are conditions that are inflammatory or induces an inflammatory process. We know that obesity is really a chronic inflammatory process. So that contributes to inflammation. If we alter our microbiome, whether it's in the gut or whether it's at the cellular level, that can induce inflammation. I spoke earlier about vitamin D deficiency. Also, there are environmental toxins that we get exposed to. In my early professional career, we did a lot of work looking at estrogen disruptors. So there are estrogen-like active substances that can be found in our water and some of the other toxins that's in our environment. And then, of course, there's the increase in estrogen responsiveness, which increases chronic inflammation. And as a result of that, what we see is damage to the DNA, and there may be an impairment in how that cell is repaired, because we're constantly turning cells over and repairing them. But if there is a disruption in the repair process, then we have abnormal cells to develop. And that's when we see uterine fibroid cells. We get a mutation of the MED12 genome, and fibroids develops. So what do we know about fibroids, and what do we know about how we treat fibroids? Well, one is that we know it's more common in women of color. We know that there are adverse environmental toxins, which I spoke about. We don't really know exactly the direct impact, or if we are exposed intrauterine, so developmentally, are we exposed, or are there transgenerational exposures that contributes to the development of fibroid? And then there's the role of really how uterine fibroid cells translates this DNA and production. We've got, many times we have what we say is epigenetics. So we've got interruptions of our genome transcript, and you get unusual or abnormal cells that just begins to develop. We're constantly looking for fertility-friendly therapy, because fibroids, especially in African American women, occurs earlier. And so women want to preserve their ability to reproduce. So we have to have the option of offering them treatment that will preserve their uterine or uterine sparing treatment. And ultimately, what we would like to do is to have prevention of fibroids. If we know women are prone to fibroids, we can identify those that are perhaps developing fibroid very early on, and then evoke treatment that will arrest the growth, or perhaps even before they start, we might have treatments that we can use. So let's talk a little bit about the impact of symptomatic uterine fibroids. So uterine fibroids are associated with a number of symptoms that can cause pretty significant burden for women. About 50% of women who have uterine fibroids are symptomatic. And some of those symptoms include heavy menstrual bleeding, abdominal distension or distortion, anemia and fatigue. Sometimes we have women who are so anemic they need blood transfusions. Prior to the Affordable Care Act, there were many times when we had patients who would present to the emergency room so severely anemic they would have to be transfused. We couldn't really treat them. We couldn't do any surgery. We didn't have medications that they could afford. And so it became sort of a revolving door. Well, fortunately, we have improved coverage for women across the country. And so we see less of that happening. But some of the other symptoms, like pressure symptoms, pelvic pain, especially if the fibroids rapidly grow, they may outstrip their blood supply and cause pain because they start to degenerate. Painful menstrual cycles, dysmenorrhea, And of course, one of the areas that I am most focused on is the impact of fibroid in terms of infertility and recurrent miscarriages, which I mentioned earlier. Of the patients that are symptomatic with fibroids, 73% of them complain of heavy menstrual bleeding. So it is by far the most common symptom that we see in women with fibroids. The burden to those women ends up being in multiple areas related to impacting their quality of life. What we know from statistics is that women may lose an average of almost 8 to 12 hours of work productivity per week. That's huge. And it's a combination of absenteeism and presenteeism, because if you're at work and you're worried about soiling, bleeding through, or you're having severe pain, then you may be present, but you're not optimally functioning. So it has significant impact on quality of life for women. So we talk about the burden of uterine fibroids, particularly for African Americans. And again, largely because when we look at fibroids affecting African American, we are affected disproportionately. Upwards of 80% of African American women by the age of 50 will develop uterine fibroids. We have a threefold higher risk of developing fibroids, and fibroids, our conditions or our symptoms associated with fibroids are typically more severe because we tend to have greater numbers and larger size. One of the other factors that we have seen is that for white women, when they go through menopause, their fibroids start to shrink. We don't necessarily see the same growth deceleration in African American women as we approach menopause. And then we have a threefold risk of developing anemia. So significant burdens associated with that. Combine that with the fact that the onset, we typically tend to develop fibroids about 5 years younger than our white counterparts. Other disparities, we are about 2.5 times more likely to undergo hysterectomies than white women, as well as about 7 times more likely to undergo myomectomies. So before any drug or any therapeutic option comes to market, we have to do clinical research. And historically, we have had challenges recruiting African American or Black women for clinical trials. So we have been underrepresented in many of the clinical trials that have studied fibroids. However, recently, a very close colleague of mine has brought a drug to market and has been very successful in recruiting Black women. They looked at what some of those barriers were. And as you can imagine, for African American women, we oftentimes are in essential workers positions, so we don't have a lot of autonomy where we can miss work. So participating in clinical trials may be prohibitive, maybe cost prohibitive. Maybe you miss work, you miss salary compensation, or it may be transportation issues. It may be a number of different barriers. So they looked at what those barriers were and really structured their incentives for participation in clinical trial to try and offset what some of those barriers and burdens were for African American women. They gave them, tokens or ride to get to the clinical trials, et cetera. So things like that. So let's talk a little bit about what happens. There's just a psychosocial experience that Black women have when they seek treatment for uterine fibroids. So this was a study looking at single college-educated women that were interviewed when they showed up seeking treatment for fibroids. So they knew they had fibroids, right? What were the influencers of their decision? First of all, was their patient-doctor interaction. And we talk right now ad nauseum about culturally competent care. Not all patient-doctor interaction and conversations are the same. So how that information is perceived. Is the physician listening to the patient? Are they hearing what they're saying? So hear her, right? And if they're hearing it, are they incorporating what they're hearing into what they may be offering the patient in terms of treatment options? What are her social networks? What's her support of how she gets her information? And what fertility consequences needs to be considered? Is she young? She still hasn't had any children. Those are important consequences. Or if she's had children and she wants to have further, to extend her family further. Does she have a fear of fibroid malignancy? Now, fibroids are 99% benign, but many patients don't know that. So they may be worried about it being a cancer. What are our community norms? What's our knowledge? What's our awareness? I am always astounded by the number of Black women who come in and they're told they have fibroids, and it's the first time that they've ever heard of fibroids. Well, as common as it is in our communities, one would think that we would be a little bit more knowledgeable, that we're talking about it among our friends and families. And so we do have to do that more frequently. And then, of course, there's the distrust of medical communities, both from a historical perspective and a current perspective of how Black women have been treated in being used experimentally in developing procedures. Also, when we look at the research, the earlier research, and how we used Black women. And now there's still concerns about Black women feeling like they are devalued, right? That they are not, their reproduction, their lives are not as valuable as white women. So we have to make sure that we mitigate against some of those concerns and acknowledge them, address them, and fix them. Also, that alternative options are oftentimes not discussed. And, that hysterectomy may be the only option that they are offered. And really, fibroid is what we consider to be intersectional, right? It is in the intersect of gynecological care, but there's also the issue of genderism and racism that comes to the forefront when we start to have these conversations with patients about fibroids. And lastly, I want to point out that Black women in general are more opposed to surgical options compared to white women. So if the only thing that they're offered is surgical options like hysterectomy or even myomectomy, that may not be acceptable for them. And so they will, instead of seeking or getting any other care, they just kind of disappear. And if that happens, of course, they risk the chances of the fibroids enlarging and becoming more symptomatic. And so when they do present for treatment, it may be more difficult to treat them, right? So, one of the things that I hear from our patients, again, is that oftentimes hysterectomy is their only option. And they'll say when they figure out that they have other options, they're infuriated by it. So it's incumbent upon us, it's imperative that we as a community, we speaking Black community healthcare professionals, that we make sure we talk more about what some of those options are and educate patients. So what are some of those treatment options? What does that landscape look like? We're talking about treating women who are symptomatic, because those are the ones that's going to show up in the office. And the first thing that I ask is, are you planning on having more children? So future pregnancy, is that part of the decision-making touch point? Have they, in fact, completed childbearing? That's a completely different discussion. But with future pregnancy, we're talking about uterine sparing options. So whether it's medical, whether it's interventional, perhaps radiology, or whether it's surgery, we are working to preserve the uterus so that their reproductive capability remains in situ. If they've completed childbearing and they're okay with the option of hysterectomy, then removing the uterus may be the best option for them, again, depending on their history and depending on their beliefs. It is absolutely not necessary to do a hysterectomy for fibroids. It is rare. Hysterectomies are really needed when we're talking about treating cancer. But if someone has such a huge burden of fibroids, it may be the best therapeutic option for them. So we'll walk through some of the medical management, interventional options, and surgery, right? So when we talk about medical management, one of the things that we really do focus on is physiologically, we know that estrogen levels, the higher the estrogen levels, the more likely it is that women can develop fibroids. So when we look at our therapeutic options, we really are trying to bring the estrogen levels down into a therapeutic range, which usually results in shrinkage of uterine fibroids, right? So if we're down in the range of someone who is very early in proliferative stage of their menstrual cycle, here this would be menopausal range, and we know that we can shrink fibroids if we're in menopausal range. But as the estrogen level increases, so does the risk of fibroid growth or stimulation of fibroid lesions. Counter that with some of what we have to balance when we look at some of our therapeutic options is if we drop the estrogen levels too low, then we start to lose bone. And we have some limitations in terms of what and how long we can use treatment options because we don't want to induce osteopenia or osteoporosis. So we want to minimize bone loss. So let's just kind of walk through some of this in terms of the decisions and directing what is the patient's goal, right? So under medical options, we have good old non-steroidal anti-inflammatory drugs. We talked about fibroids being induced by an inflammatory condition. So Motrin, Advil, non-steroidals may be an option. It may certainly reduce the amount of bleeding that women experience. We have combined oral contraceptives that we use, again, that reduces the bleeding, as well as progestin only, IUDs or pills that we can use. And then we move up the tier. We move up the cost of the therapeutic options, which would be things like gonadotropin-releasing hormone analogs, so either an agonist or an antagonist, which we'll talk about in a minute. The other options are aromatase inhibitors, which really blocks the production of estrogen. It's frequently used in breast cancer patients, but more recently, we've had publications that's looked at the use in treatment of uterine fibroids and endometriosis. And then some of the other medications, not really approved in the US, but in our European market, we've got selective progesterone receptor modulators. We've had a number of clinical trials that we're looking at in that area, and antifibrinolytics, which would, of course, induce more clotting. We have drugs that fall into that category. We'll talk about in a minute. The other arm is procedural, surgical, or non-surgical. So non-surgical would include things like uterine artery embolization or MRI, magnetic resonance guided focused ultrasound. Both of these, however, are not at this point approved for women who are planning future pregnancy. Can you still get pregnant after those are done? Absolutely. We just don't know what the risks are. Same thing is true for our radiofrequency fibroid ablation. We can do this laparoscopically or transcervically. We still don't have enough data to say that it is okay to have future pregnancies post. So myomectomy is really the gold standard of treating women who are interested in preserving their future fertility. And then, of course, I indicated earlier that hysterectomy would be sort of the last resort. And certainly when we talk about hysterectomy, that's removal of just the uterus versus a hysterectomy with bilateral salpingectomy. So you can remove the tubes and you can leave the ovaries in place. And we know that the data in terms of removal of the ovary, you should not remove a woman's ovaries as long as they're under age 65, because there are some consequences related to life expectancy and other comorbidities that increases when women undergo oophorectomies. So we currently do struggle when we talk about managing uterine fibroids. About half the women who are being treated, they're symptomatic, right? And they're being treated, but they're still experiencing moderate to severe symptoms, half. And when we look at the US studies of women concerned about treatment options for fibroids, 79% of them say they do not want, they want a non-invasive treatment option. They do not want an invasive treatment option. So long-standing options that we've used in the treatment of uterine fibroids really falls into a couple of buckets. One is the medications that we use that is not FDA approved, so not specifically approved for treatment of fibroids. Is it okay that we use it? Yes, because there are lots of medication that we use which are off-label. And so oral medications like tranexamic acid, which reduces bleeding with uterine fibroids. We can put a progesterone only IUD in. Again, we're reducing bleeding. Or we can use good old pills, oral contraceptives, that can also reduce bleeding. Neither one of those does anything, however, to shrink fibroids, to reduce the size. And then we have, we're beginning to see an increase in the number of options that are FDA approved. So licensed specifically for uterine fibroids, the first category that came to the market is a GnRH or gonadotropin releasing agonist. The only options there is actually an intramuscular injection. We have some limitations in terms of how long we can use it, because I mentioned earlier we're balancing bone loss with how long we can treat patients, and we're also balancing severity of symptoms. So they tend to induce menopausal symptoms like hot flushes, night sweats, sleep disruption. So if we're trying to treat someone's fibroid and we want them to adhere or be compliant with the treatment option, we want to make sure that they are not plagued with very bothersome symptoms. So we can add back low-dose estrogen and progestin in those conditions. We still, however, when we look at the indication to use GnRH agonist, they're indicated really for preoperative management of fibroids. So patients that we're planning to take to surgery for myomectomies, if we're trying to shrink them so that we can take a less invasive or less aggressive approach to removing the fibroids, especially in terms of incisions. And then if they're severely anemic, then we can actually shut off the bleeding so that they can restore normal blood volume before they go into surgery and have to increase or endure the risk of transfusion. So that initially was all we had in our toolbox. So we knew we needed newer options, right? So enter some of the oral gonadotropin releasing hormone antagonist. So now instead of just injectable, we have an oral option. And we have an oral option that has other benefits. One is GnRH receptor antagonist. The way that the agonist works, that I spoke about earlier, is they bind the GnRH receptors in the hypothalamus, but they don't automatically shut them off. You may get some stimulation, which is different from when we have GnRH receptor antagonists. They bind the receptor, they immediately shut them off. And so what we don't see is a release of LH and FSH from the pituitary, which is what drives the ovaries, the ovarian production of estrogen and progesterone. So we really are blocking that pathway, which signals to the ovaries to produce estrogen and progesterone. So again, we're reducing that estrogenic level. And by reducing it, what we see is a shrinkage in fibroid and a reduction in bleeding. Many of patients become completely amenorrheic. So the newer options that we have, 2 of them are FDA approved, specifically for the treatment of heavy menstrual bleeding associated with fibroid. And we still have one that's under investigation, so in the clinical trial arena. So elagolix has estradiol and norethindrome acetate added back. So this is the add back at lower levels, which really minimizes or mitigates, again, some of the menopausal symptoms that may plague women. The relagolix does the same thing. They have some add back. The advantage, obviously, is that these are oral options. The regimen is slightly different for each one of those, but they can be used for up to 24 months. So we can use them for a longer period of time. So if we have someone who we're trying to perhaps bridge to menopause, then we may be able to use that. Or for younger women who are very symptomatic, and we're trying to bridge them getting to seeking or attempting pregnancy. They may be used in that way, right? So Dr. El-Hindi, I have had the pleasure of working with. He was my vice chair when I was chair of OB at Meharry Medical College. And he and one of his colleagues wrote an article really looking at how we approach the treatment of uterine fibroids. And in an ideal situation, what would we want? We really would want something that is primary prevention, right? So for women who are at high risk of developing future fibroids, we want to be able to begin a treatment that would prevent them developing fibroids, or that would arrest those fibroids in their early stages. If they've already developed fibroid, then what are our secondary prevention options? We're talking about fertility preservation, which we mentioned earlier. So we may want to protract the progress of uterine fibroids or prevent recurrence. So when I remove fibroids by doing a myomectomy, it doesn't prevent new fibroids from forming. So how do we do that? We need to have some options that can help us. And when we talked about the ability to use the oral GnRH antagonist, that may be an ideal situation as well. Or women who are perimenopause, not quite menopausal. Or if we're talking about patients who we know have minimal or mild disease, but again, we're trying to halt the progression of disease and help them to preserve their future fertility because they're not quite ready to pursue pregnancy immediately. And then, of course, patients fall into the treatment bucket. So these are women who are so symptomatic. Now we're taking them down that treatment option or algorithm that we talked about earlier. So this is really what it looks like, right? We've got medical options, we have interventional radiology options, and we have surgery options. And one of the things that we know is we really want to drive our treatment options towards less invasive and lower side effects, right? We want to drive away from hysterectomy as being the first thing that's offered to a patient, really to more limited or targeted therapeutic options. So what does that future paradigm in terms of treatment look like? Well, first of all, we talk about the physician-patient conversation and a shared decision-making process. We want to find the best option for her. So first of all is, do we hear her, right? We got to hear her. And so if she's diagnosed with symptomatic uterine fibroid, the first thing that we really are talking about is medical therapy options. So in the absence of a surgical emergency, what can we offer patients for treatment options non-surgical? And if she is not responsive to the therapeutic or the medical options that we've offered her, she's unresponsive, she can't tolerate it, right? So now we're talking about surgical or interventional options. And that's when we engage the conversation, obviously, about future reproduction in particular, and walking down those options I mentioned earlier, whether it is a myomectomy, which is really the only procedure that we know is okay to get pregnant with afterwards. The other non-surgical options may be uterine artery embolization. We can do an endometrial ablation, which addresses her bleeding, but it doesn't necessarily shrink the fibroids. It addresses the end result of fibroids. If there's fibroids in the cavities, we still have to remove those before we can do or effectively do an endometrial ablation. And then there's the high frequency ultrasound that I mentioned earlier. So the goal of therapy is really to eliminate symptoms while preserving the uterus whenever possible. And the American College of OBGYN says we should support women in pursuing alternatives to hysterectomy, irrespective of their gestational intention. And that's largely because hysterectomy is not without consequences. There may be some long-term comorbidities associated with even removing the uterus. We talk about impact on women's sexual health. That's one thing, right? Certainly, we may be compromising ovarian function. So we may actually precipitate earlier menopause, and that has consequences. So if we don't have to do a hysterectomy, then we should avoid it. And at this point, I am hopeful that you got a lot of information related to women who are symptomatic with uterine fibroids. You have a lot of options prior to anything as dramatic or drastic as a hysterectomy. And so make sure that you have that conversation with your physician and educate yourself further as to what those options may be. You can go to the websites, the professional organizations that I shared with you earlier, or to those nonprofit organizations that are patient advocacy groups, because they just have a wealth of information, as well as support groups that are active around the country. And with that, I'd like to thank you for allowing me to share this time with you, and have a great day.